Hello, the undergraduate student who are watching this video, most welcome. Today I am going to talk on some topics related to pain. Pain are transmitted from the receptor, that is the peripheral nervous system, to the central nervous system by several order of neuron. In the peripheral nervous system, there are two type of neuron. Number one, the myelinated nerve fiber, and number two, non-myelinated or unmyelinated nerve fiber. The myelinated nerve fiber carry the well localized pain, that is sharp pain, and also the thermal sensation carried out by the myelinated nerve fiber. On the other hand, the unmyelinated nerve fiber carry the poorly localized pain, that is the diffuse pain, such as the visceral pain. As we know, the visceral pains are dull, aching, diffusely, not localized pain. So these are the two type of nerve fiber through which the pain are carried out. Now, what are the neurotransmitter associated with pain? That is the neurotransmitter which are released in response to pain. Okay, there are three main group of neurotransmitter. Number one, amino acid group. There are three main amino acid which act as a neurotransmitter in pain transmission. Number one, the glutamate. Number two, glycine, and number three, GABA. Here the glutamate is the excitatory neurotransmitter. On the other hand, the glycine and GABA, both these two are inhibitory type of neurotransmitter, and very important to know that glycine is derived from glutamate. Okay. The number three neurotransmitter is neuropeptide group of neurotransmitter. Here the most important neuropeptide that act as a neurotransmitter is substance P, then cholecystokinin and calcitonin gene related protein peptide. Calcitonin gene related peptide. All these three are excitatory type of neurotransmitter. Okay, that means the increased level of these neuropeptide increase the transmission of pain signal in the central nervous system. Okay, number three neurotransmitter are opioid group. Number one, dynorphin, number two, endorphin, and number three, nociceptin. Here the dynorphin is excitatory type, and endorphin and nociceptin are inhibitory type. That means the high level of endorphin and nociceptin decrease the transmission of pain signal in the central nervous system. So these three group of neurotransmitter in pain transmission: amino acid, neuropeptide, and opioid. And in opioid, most important one is endorphin. Mind it, endorphin, the opioid neurotransmitter, and we can modulate the function of these endorphin and nociceptin. Now now I will talk on the clinical features of neuropathic pain. That means the on history, the patient will say the type of pain. Most important clinical features of neuropathic pain, mind it, most important clinical features of neuropathic pain is the pain is spontaneous in origin, spontaneous. No stimulus is required for neuropathic pain, and as these cause patient feel pain at night, and patient may have sleepless night, as because patient feel the pain all the day and night, so patient have no scope to sleep quietly. So number two neuropathic pain symptom is some positive sensory disturbance. Mind it, there are some positive sensory disturbance and negative sensory disturbance. At first I talk positive sensory disturbance. Light touch sometimes for the patient may be painful, and this is called when the light touch become painful, the condition is called dynamic allodynia. And pressure may be also painful, that is called punctate allodynia. And pinprick itself produce some pain, but in this neuropathic patient, pinprick increase produce the high level of pain, and this increased level of pain on pinprick is called hyperalgesia. Mind it. And cold and warm temperature, that is variation in the temperature, also produce pain, that is called thermal allodynia. And number 3, the negative symptom, negative sensory disturbance in neuropathic pain, that is the patient might have numbness, that means loss of sensation. Patient have no sensation on the affected part like lower limb or upper limb. And tingling, that is a paresthesia. What do you mean by paresthesia? Paresthesia may be burning sensation or prickling sensation or pin or needles, বাংলায় আমরা যাকে বলি জ্বালা পোড়া করা. So tingling or paresthesia is the same word but different expression. And loss of temperature sensation, patient may have no sense of temperature. Okay, so these are the negative symptoms. Now there are some other symptoms, like patient may complain that patient, he or she feel the some insect crawling over his skin. Insect crawling over his skin, that is called formication. Mind it, very important term, formication. Affected area feel abnormal. Patient sometimes it is very difficult to explain for the patient the symptom. So patient call it the affected part just abnormal. So these are the symptom of neuropathic pain. Pain, the most important is spontaneous, then some positive sensory, important light, touch, pressure, pain and cold and temperature produce pain. And there are most important negative symptom, most important numbness, another formication, that is insect crawling over skin. Okay, next I'm going to talk on the pharmacological management of a neuropathic patient. That means how will you manage this neuropathic pain patient with drug. At first, assess the patient from the symptom. Is there any clinical features? What I already explained here, that suggest the neuropathic pain. If the clinical features are suggestive of neuropathic pain, then assess the patient by examination. And if your clinical examination finding, the clinical examination finding may be 3 category: possible, probable and definitive. If it is possible case or definitive case of neuropathic pain from your symptom analysis and clinical examination, then go for treatment without at first stage without any investigation. The first line treatment will be TCA, tricyclic antidepressant such as amitriptyline, and you may combine, you may give gabapentin or pregabalin or SNRI, that is serotonin noradrenaline reuptake inhibitors such as duloxetine or venlafaxine. These are the first line therapy for neuropathic pain. And assess the patient for after 2 weeks. If the response with this drug is good, then continue with this drug. But response is not well and good, or poor response or no response, then go for second line treatment. The second line treatment will be with a capsaicin patch, lidocaine patch or a tramadol. Actually in reality we use a tramadol as second line therapy. And again follow up after 2 to 3 weeks, and if the response is good and well, then continue with the above drug. But if the response is not good or very poor, then go for third line drug. Third line drug are botulinum toxin and a strong opioid. Actually in clinically botulinum toxin is not used. Usually we use a strong opioid like morphine and oxycodone. Mind it, morphine, oxycodone are strong, and codeine and dihydrocodeine are weak. On the other hand, tramadol are moderate activity opioid. So here we use morphine. So through this algorithm is taken from the Davidson medicine. Through this algorithm we can treat the patient with neuropathic pain at first symptom, then on examination and treatment. Sometimes we can go for an MRI or X-ray, or sometimes biochemical and hematological such as CBC, ESR or C-reactive protein we can advised patient. Okay, so thank you very much for your watching. Hope this clinical video will help you. Thank you again.